Today I'll be talking about coronary bypass and valvular disease. Now, during my presentation, I'll be hitting most of the highlights about the surgical management, diagnosis, and treatment for coronary artery bypass and valvular disease. Although this is not a comprehensive list of all the possibilities, it does reflect what is the most current knowledge of these two medical issues, as well as give enough information about the most common presentations and the treatment options. So I have no disclosures that are relevant to the presentation. However, I do have a consulting agreement with Abbott and Abiomed. I'll start with discussing the surgical management of coronary artery disease. I'll then talk about aortic valve disease and also discuss about one of the newer treatments, which is a transcatheter aortic valve replacement, or TAVR for short. We'll also talk about mitral valve disease with both degenerative mitral valve regurgitation and ischemic mitral valve regurgitation. I'll also touch up on tricuspid valve disease and endocarditis. And throughout the presentation, I will also discuss some of the most recent guidelines about each one of these diseases as well. So let's start with coronary artery bypass. So I'm going to start with a brief history of coronary artery bypass, and it really puts everything in historical context and perspective. I'll talk about what are the choices of the conduits that are used, what are the patients that are appropriate for PCI versus CABG, how to manage patients with low ejection fraction, and finally a few slides about redo coronary bypass as well. So coronary artery bypass started in the 1950s with what was called the Weinberg procedure. The Weinberg procedure was essentially using the internal mammary artery or the internal thoracic artery and sewing that artery directly into the myocardium. However, it wasn't until 1962 when Mason Sones, who was a cardiologist doing angiography, discovered that the coronary arteries could be directly engaged and injected to diagnose coronary disease. And since that time, we now had a very repeatable way of diagnosing coronary disease. And Rene Favillaro at the Cleveland Clinic, with collaboration with Mason Sones, was then able to develop a repeatable operation, which was a coronary artery bypass, and demonstrated the success of this operation in a large amount of patients. In the 80s, Lube, Cosgrove, and Lytle at the Cleveland Clinic identified the superiority of the internal thoracic artery as the conduit of choice. And in the 90s, we saw an increase in the number of off-pump CABGs being done. And in the 2000s, we also saw robotics and hybrid procedures being offered as well. So Rene Favillaro was credited as being the father of a coronary artery bypass. Although he wasn't the first surgeon to perform a coronary bypass, that was done by Dr. Michael DeBakey. He was nevertheless the first surgeon who was able to show in a large series that this procedure was beneficial for a lot of patients. In 1970, he published his study with a coronary artery bypass on 300 patients and showed excellent clinical outcomes with a mortality of less than 5%, which was quite remarkable at that time. This was one of the angiograms of the first patient. The patient had a very tight disease in the LAD, and the vessel was bypassed with a saphenous vein graft. Now, over time, as a number of coronary artery bypassing increased, it peaked in the mid-90s, and that was also around the time where PCI became more readily available. And as PCI also became available in more and more places, the number of coronary bypass started to drop. However, in recent years, we've seen again an increase in number of coronary artery bypass, and currently there's about 300. There's currently about 300,000 open heart surgeries done in the United States every year, and about half of those are coronary artery bypasses. And that represents one of the most common surgeries in all of surgeries in the United States being performed today. And the benefit of coronary artery bypass is that it doesn't just bypass the current lesion, but also bypasses possible future lesion. Because you are using a graft to bypass the patient's disease, any additional disease that develops in that vessel between your bypass and the aorta will also gets bypassed as well. Therefore, you're not just treating the culprit lesion, but protects against future lesions, which is why historically bypasses have always held up better compared to PCI. And I'll show you some of the more recent evidence in some later slides. But first, I want to touch about the choice of conduits. Historically, saphenous vein was the main conduit that was being used. And in the 1980s, large studies from a Cleveland Clinic by Loop and Cosgrove and Lytle showed the superiority of the internal thoracic artery compared to the saphenous vein. And the patients who had the internal thoracic artery to the LAD had a much better survival, both in the short run and also in the long run. And that difference increased over time. Now, if one mammary artery was good, then two must be even better. And this was also shown by Dr. Lytle and colleagues at the Cleveland Clinic in the early to mid 2000s. Patients had had a survival advantage, but this difference was only manifested 10 years after the bypass, and mainly because of the patency rates of the internal thoracic artery, and you don't see that advantage over saphenous vein until many years later. This was true in all groups of patients at all ages. In all age group, age 30, 50, and 70, you saw superiority in the survival in favor of the bilateral internal thoracic artery, as well as in patients with normal ventricular function or with a left ventricular dysfunction. Bilateral internal thoracic arteries proved to be better with a better survival long term. The other conduit, arterial conduit that's been used is the radial artery. In the early studies in the 80s, the radial arteries did not have a good long-term outcome. However, over time, we recognize that the radial artery is a very muscular vessel and require calcium channel blockers. And once these patients are managed with calcium channel blockers and placed on arteries that are tightly stenotic, the outcomes with radial artery has been quite good. In the RSVP study published in Circulation, you can see that the radial artery had a patency rate that was superior to that of the saphenous vein. And at the 10-year patency of a radial artery tends to be about 80%. Despite the benefits of multi-arterial revascularization, this is still an underutilized procedure, and only about 5% of all coronary bypasses done in the United States are using bilateral internal thoracic arteries, and this may be related to the complexity of doing a bilateral internal thoracic artery, to increase time that it needs. However, nevertheless, this is still a procedure that is very beneficial and is still offered in a lot of places. Looking at the usage of arterial revascularization or total arterial revascularization in the United States, looking across the country, only about 5% of patients had bilateral internal thoracic arteries used. In large academic institutions, that number is slightly increased at around 8%, and here at the Cleveland Clinic, we use about bilateral internal thoracic arteries are used in about 24% of patients. The usage of a radial artery is also about 5% of all cases, and here we use it in about 11% of cases. And to summarize, regarding the choice of conduits, the usage of the left internal thoracic artery is absolutely mandatory in all patients. In patients who are younger than 70 years old, who are not diabetic, we also will use a bilateral internal thoracic artery, plus minus a radial artery when appropriate. In patients who are diabetic and under 70 years old and who are non-obese, we still use the bilateral internal thoracic artery plus minus a radial. However, in patients who are diabetic and obese or who have poorly controlled diabetes, we will just use a single internal thoracic artery and use a radial artery as a second arterial conduit. In these patients who are diabetic and obese, using both internal thoracic artery increases the risk of wound complications, and in that group of patients, we tend to shy away from using both internal thoracic arteries. It is important to note that when a radial artery is being used, it should be used on a lesion that has at least a 70% stenosis and preferably a greater than 90% stenosis. The greater the degree of stenosis, the better the long-term patency when it comes to the radial artery. Looking at the guidelines, the STS guidelines for usage of arterial conduits, the ITA should be used to bypass the LAD whenever the bypass of the LAD is indicated, and this has level 1 evidence. an adjunct to the LIDA, a second arterial graft using either a right internal thoracic artery or radial should be considered in appropriate patients, and this has a two-way recommendation, and the usage of bilateral internal thoracic arteries in patients who do not have excessive risk of sternal complications also carries a 2A recommendation. Now, looking at CABG versus PCI, in the early 1990s and 2000s, there were a lot of retrospective studies. However, since that time, we've had a few major prospective studies looking at coronary bypass versus PCI. And the most important study of all of these was the Syntax trial. In the Syntax trial, essentially what the authors did was it took patients who they felt had equipoise and randomized 1,800 patients to CABG versus PCI. And some of these patients were three vessel disease patients, some of these patients were left main disease patients. And they separated these patients to what's called the Syntax score, which is really a representation of how complex the lesions are. So the more proximal the lesion, lesions that are long, lesions that are bifurcating vessels, all carry a higher higher complexity and thus have a higher Syntax score. And these patients are separated into three groups: low complexity, medium complexity, and the high complexity. Looking at the overall results at 5 years, we can see that in the low complexity group, there really wasn't much a difference in MACE outcomes. However, in the medium complexity and at the high complexity group, CABG patients, which are in red, had improved outcomes when it came to major adverse events, and particularly when it came to need for repeat reinterventions. When you look at the left main subgroup, in the left main subgroup, only the high-risk Syntax group patients did better with coronary bypass. And if you look at the three-vessel disease, you see an early signal even with the low-risk group patients, but particularly when it came to the medium and the high-risk group patients, CABG patients ended up doing better. When you look at, when you divide the subgroup even further and looking at the diabetic patients, this is the group of patients that truly did much better with the coronary bypass versus a PCI. Now, next, I want to shift our focus to managing patients with low ejection fraction. These are patients who typically have a much higher operative risk, mainly because with low ejection fraction, you run the risk of having cardiogenic shock and having these patients fail due to cardiogenic shock coming out of the operating room. And these are the group of patients that typically are shied away from in many centers. What's important when you evaluate these patients is really try to get a good appreciation of what the myocardial potential for recovery is. In patients with ischemia, the myocardium could be stunned or they could be hibernating. Just like animals in the wintertime when there's no food, they go into hibernation. The myocardium can be the same. So in the setting of a myocardium that's lacking blood flow, often the myocardial function would be decreased, but that myocardium can recover once the revascularization is complete. The trick here is you got to try to understand which myocardium will be able to recover and which will not. There are two ways that we assess the myocardial function. One is a nuclear study, or what we call the PET scan, using a tagged red blood tagged glucose, and also we can use an MRI using a gadolinium contrast. So when we look at the PET scan, we're looking at two things. We're looking at perfusion and metabolic activity. In patients who have normal perfusion, this is a viable myocardium, and that myocardium will recover. In patients who have a decreased perfusion but have a normal metabolic activity, this is also a viable myocardium, and that myocardium should recover. However, in patients who have a decreased metabolic activity and decreased perfusion, that territorial muscle is likely a scar and unlikely to recover. When you look at the MRI, you're looking at it in reverse. You're looking for evidence of scar. If you don't see scar, then that muscle should be viable and should recover. And using a gadolinium, the gadolinium will enhance any scar that you see, and it also gives you an appreciation of how thick or how thin that muscle is. The thinner the muscle, the more likelihood that this is a scar and unlikely to recover. The advantage of the gadolinium is that it also gives you an idea of what the thickness of the scar is in proportion to the entire thickness of the myocardium. In patients who have no scar, the dysfunctional segments will recover in about 80% of cases. In patients who have a mild scar, with scar that represents less than 25% of the thickness, many of these myocardium would also recover. However, the greater the amount of scar as a proportion of the thickness of the total myocardium, the less likely you are going to have myocardial recovery. Now, off-pump versus on-pump is something that's been debated quite a bit over the last 30 years. And in the 1990s, there was an increased enthusiasm for off-pump surgery because it was perceived to be less invasive, with possibly less morbidity and mortality and less risk of stroke. There's been two large randomized clinical trials looking at the difference between on-pump versus off-pump. One was the Ruby trial done in the VA hospital system, and showed that there was essentially no difference in survival. However, patients who had off-pump surgery had a much higher need for reintervention in the future. There was a second study called the Coronary trial, and the difference with the Coronary trial was that all the surgeons who participated in a coronary trial had to have a minimum number of requirements, and these were all deemed experts in the field. And when you had experts in the field comparing these two modalities, there was no difference in outcomes in both the short term and the long term. You could see both of these curves completely superimposed. Now, what about strokes? There's been a lot of talk about how off-pump surgery may be associated with less strokes. If you look at the stroke rates between all three of these studies, as well as a Cochrane review, you can see that there was absolutely no difference in stroke rates between on-pump and off-pump. Now, due to the lack of clinical benefit, the enthusiasm for off-pump surgery has since waned, and the number of patients in the United States, or the percent of patients in the United States on off-pump peaked around the early 2000s, has since steadily declined. There are many countries, however, like India and China and some places in Europe, where the predominant choice for coronary bypass remains off-pump surgery. So this is still something that is offered in many places. And we have shown that in skilled hands, both techniques can yield equally good outcomes. So just to summarize, for coronary artery bypass, in the guidelines, patients who have left main disease should undergo CABG, and this is a level 1 evidence. Patients with triple vessel disease, with or without proximal LAD disease, also should undergo CABG with level 1 evidence. And level 2A evidence suggests that it is reasonable to choose CABG over PCI in patients with complex triple vessel disease. In patients with two vessel disease with proximal LAD disease, also you have level 1. Patients with two vessel disease without proximal LAD disease, but who have extensive ischemia on testing, carry a 2A recommendation, and those without extensive ischemia carry a 2B recommendation. Patients with proximal LAD disease carry a 2A recommendation when the LEMA can be used, and patients without proximal LAD disease but with only single vessel disease, CABG should be avoided in these patients, and PCI would be a better alternative in these patients. In patients with LV dysfunction, those with an EF of 35 to 50% carry 2A recommendation, and those with an EF of under 35% carry 2B recommendation. And finally, patients who had ischemic VTs also would benefit from a CABG with level 1 evidence. And finally, when there are no suitable targets for vascularization, these are the type of patients that would have harm and that should be avoided for surgery. Now, I'm going to switch gears and talk about aortic valve disease. I'll talk about the indication for surgery, the choices of valves, some surgical considerations, as well as special situations. The most common way of diagnosing aortic stenosis is with echocardiography. On echocardiography, there are three determinants of a valve stenosis severity. One is the jet velocity, looking at the velocity of the blood flow as it comes across the aortic valve. We have the gradient or the pressure difference before and after the aortic valve, as well as the valve area. And typically, what we consider severe would be those patients with a jet velocity of more than 4 meters per second, with a mean gradient of 40 and a valve area under 1 centimeter squared. We know from patients with aortic stenosis on natural history studies is that these patients tend to have a pretty good prognosis until they develop symptoms. The chances of these patients having sudden death is approximately 1% a year. The risk can be variable from person to person. In patients with aortic stenosis, we know that patients who have symptoms do far worse than patients who are asymptomatic. And this was known even back in the 1980s through this study from 1988. Patients with symptomatic aortic stenosis had a much worse survival, as well as a much higher risk of sudden death and cardiac death. So the model for aortic stenosis has always been that patients with a severe aortic stenosis that are asymptomatic, they will enter a period of latency, and once they start developing symptoms, then the survival drops off precipitously. Therefore, historically, these patients were always offered surgery as soon as the symptoms start to arise. However, we know that follow-up is not always complete in all patients in all places, and it's often difficult to identify when exactly this happens, this inflection happens. This was a study by Bromwald back in 1968 that this natural history of aortic stenosis was described. And over time, we know that the patients who have aortic valve replacement do far better than patients with no aortic valve replacement and patients with aortic stenosis. So if you look at the model of when to operate on a patient or when to operate on a patient with any disease, we're always considering what is the risk versus what is the benefit. The surgical risk historically was about 3 to 6% risk of mortality with aortic valve replacement. However, the risk of cardiac death, spontaneous cardiac death, was only about 1% a year. Therefore, back in the 1960s, it was always thought that the greatest risk for asymptomatic patient with severe aortic stenosis is premature surgery itself, and you're much likely to die with a bad surgery than you are with your disease if you're asymptomatic. However, that thought has changed considerably, and for a couple of reasons, and I'll go into. Now, when you estimate a patient's surgical risk, there are a few ways for us to be able to calculate that risk, and we have the STS risk calculator and the Euroscore. These are the two most common ways of assessing patients' risk. We're looking at the operative complexity, whether or not these patients had a previous surgery or not. We're looking at the comorbid conditions, and also the risk of going on cardiopulmonary bypass with open heart surgery have also changed over time and is now very, very low. So if you look at the predicted risk of many of these patients, looking at the STS database, this risk was calculated to be as high as 6 to 9%, depending on which score you use. However, the actual mortality was only 2%. And if you look at our experience at the Cleveland Clinic, our risk is even less. In patients undergoing primary aortic valve replacement who are under 70 years old, their risk of death is only 0.28%. Patients, even when they're older than 80 years old, their risk is only 1.4%. Even in a reoperative aortic valve replacement in young patients, the risk is 2%. And even in octogenarians undergoing redo aortic valve replacement, the risk is still only 5.6%. So these are much less than what the models would predict. And because of the better outcomes in the recent decade, the operative window have now shifted leftwards, and we tend to be operating on a more asymptomatic disease, because we also know that not all patients who are asymptomatic have the same risk profile of spontaneous cardiac death. And over time, we also recognize that the greater the severity of aortic stenosis, the worse your long-term outcome is, even after surgery. So patients here who have a valve area less than 0.5 centimeters square have a worse outcome after aortic valve replacement than those that have a large aortic valve replacement. The same is true for left ventricular hypertrophy. The greater greater their myocardium has hypertrophy, the worse your long-term outcome is even after surgery. And a lot of these patients with severe LVH or left ventricular hypertrophy are asymptomatic. This is a graph that is comparing patients who have a high degree of left ventricular hypertrophy, and if you superimpose that with a small aortic valve area, these patients do far worse than any other group of patients at 10 years. Likewise, patients with once they develop left ventricular dysfunction will have worse outcomes that you don't recover after surgery. And also, the greater the degree of symptoms that the patients have, the worse their long-term outcome. So in the most current guidelines, this is how we currently assess a patient with severe aortic stenosis, defined by a jet velocity of 4 meters per second, aortic valve area less than 1 centimeter, and a mean gradient of 40. If these patients are undergoing surgery for any other reason, these patients should have a aortic valve replacement, and this has a class 1 indication. If these patients are symptomatic, they should also have aortic valve replacement with a class 1 indication. If their symptoms are equivocal, you can stress these patients, and if these patients during stress tests either develop hypotension or develop symptoms, you have a class 2B indication for surgery. If these patients have a normal stress test but have a reduced ejection fraction, these patients should undergo surgery with a class 1 recommendation. And only if their ejection fraction is normal, they have a normal exercise test, and they're asymptomatic, then these patients should be monitored. And it's reasonable to monitor them medically. However, if you're in an area where these patients have a difficulty with their follow-up and you feel that these patients may fall through the cracks, so to speak, it is also very reasonable to go ahead and operate on these patients early. Now, I'll talk a little bit about the choice of valves, and these are really the different valves that we can use. We can use a mechanical valve, the bovine or porcine stented valves. These are the two most common valves that we use. Stentless stentless valves from pericardium and from porcine valves have also been developed. However, they have fallen out of favor, more or less because it's perceived that they don't last any longer than the stent xenografts, and they're much more difficult to implant and to remove. Homografts from cadavers have also been used. However, these are more complicated to place and have the same or if not worse durability than stented grafts, and these are now only used mainly in patients who have endocarditis. The Ross procedure is another operation that can be done where you're taking the patient's own pulmonary valve and putting in the aortic position, and then you're replacing the pulmonary valve with a homograph. In the pulmonary valve position, the homograph tend to last longer, and using the patient's own valve to replace the aortic valve may have some durability advantages. And this is a procedure that's used in some younger patients. So when we consider the various types of valve, there are 5 considerations that we're thinking about. We're thinking about what is the risk of clot formation on the valve, leading to valve mechanical failure. We're thinking about the durability of the valve. We're thinking about how easy or difficult it is to place the valve. What are their hemodynamic performances, as well as the resistance to infection. The 2 most common valves that we use are the mechanical and the stented valves because of the simplicity of insertion. The mechanical valves have a higher risk of developing thromboembolism, and these patients require Coumadin, whereas the stented valves do not, but they have a limited durability and tend to last about 15 years. The stentless valves have fallen out of favor because it is now recognized that they don't last any longer than the stented valves, and they are more difficult to implant. Homographs' main advantage is the fact that they are very resistant to infection. And then the autographs, which is the Ross procedure, These are more complex to perform. However, they do tend to be more durable and may be a valve of choice in the patients who are young. So in summary, when you're considering valves, in 95 or more percent of patients, you're considering either the mechanical valve or stented xenograft, and you're thinking about what are the risks of thromboembolism versus the bleeding complications. In the aortic position, the bovine valves tend to perform better. They tend to not only last longer, but also the mechanism of failure is also more favorable. Where the porcine valves fail, the valves tend to tear, and the patient will have a sudden onset of severe aortic insufficiency. Whereas when the bovine valves fail, this tends to be a much more slow progression of aortic stenosis, and you have much more time to intervene on the patients without the patient going into acute cardiogenic shock. The newer generation of bioprosthesis or the stented xenografts have improved hemodynamics because their stents are much smaller. They are placed in a supraannular position, and they have anti-calcification treatments that make these valves more resistant to calcium development and make them last longer. So the anticipated duration for these valves is typically around 15 to 20 years now. And this is a study that we done looking at the Paramount CE valve, which is a bovine valve that's stented. The freedom from a structural valve degeneration at 20 years was about 60% in these patients. So in summary, when you're considering patients who are young and middle age, a mechanical valve is preferred in these patients, and a Ross procedure is also possible in patients who want to avoid taking Coumadin. These are also patients that you expect that will have a much longer life expectancy, and also patients who are on dialysis. The bioprosthetic valves tend to fail much sooner in those patients, so mechanical valves may be favored in this group of patients. However, in women who wish to conceive, the Coumadin can be toxic to the developing fetus, so this should be discussed with the patients and potentially avoid in that group of patients. For the bioprosthetic patients, these are typically done in older patients with a life expectancy of under 15 years, in patients who are less physically active, because the metabolism also dictates the longevity of the valve. Decreased metabolism will lead to a longer durable valve. And in infective endocarditis, homografts are favored due to their resistance to infection. Having said that, we do have a lot of patients who are young who do prefer to have bioprosthesis, bioprosthetic valves, because they do not want to take Coumadin. And the risk of reoperation in these patients nowadays are extremely low. And this is also a good alternative for patients who do not wish to take Coumadin. Some surgical considerations. The technical aspects of aortic valve replacement involves putting in patients a cardiopulmonary bypass. We open the aorta, we take out the calcium, we place the sutures, and then we close the patient. Historically, this is always done through a median sternotomy, where the sternum is divided. We put the patients on our central cardiopulmonary bypass and we arrest the heart. However, over time, we are able to do these procedures through lesser invasive means. And now the most common way of placing an aortic valve replacement is through a mini hemiupper sternotomy, where we either go into the third or fourth intercostal space, and with through an upper hemi sternotomy, and this still gives us enough exposure to be able to place the valve. The exposure is done through a 6 to 8 centimeter upper midline skin incision, hemisternotomy. We make a J incision into fourth intercostal space. We have a special retractor that we use, and the pericardium is tacked up. The aortotomy is performed. The aortic valve is typically quite calcified, and this will be resected. The stitches are then placed for the aortic valve replacement, and the stitches then placed through the valve and tied down in place, and the aortotomy is then closed. And this is the cosmesis of the patient, which over time that scar incision becomes almost invisible. The need to convert from a minimally invasive aortic valve to a full sternotomy is only about 1.2%, and overall mortality is about 0.6% here. So we looked at we compared our patients who had a mini hemi-upper sternotomy versus a full sternotomy over a course of 10 years' time and found 800 pairs. We found that the survival was the same between the two groups. However, patients were extubated much quicker with a minimally invasive approach. There is improved pulmonary function early after surgery, and however, this difference became mitigated within just a few days. So patients do tend to come off the ventilator much quicker, and they do tend to have a much easier time with their breathing, and their chest tube outputs or bleeding is also much less with a minimally invasive approach versus conventional approach. Mini thoracotomy has also been done for these patients, and this is done through a mini thoracotomy on the right side of the chest, and patients are often peripherally cannulated in their groin, and this still gives you enough exposure to be able to complete your operation. Now, some of the special situations of patients needing aortic valve replacement will be discussed here. In patients who have low ejection fraction, you can have what's called low flow, low gradient aortic stenosis. There are two things to consider in patients with low ejection fraction. Patient may have a true aortic stenosis, but the heart may just be too weak to mount a high gradient. Therefore, when you're measuring on echo, this valve may have a low gradient, and you could be fooled based on the low gradient. Likewise, you can have a patient with just mild or moderate aortic stenosis, but the ventricle may be just too weak to fully open the valve. And you may have a situation where if you're looking at the valve area could be reduced, but this is an underestimate because of the low ejection fraction. One way to distinguish between the two is performing what's called the debunamine stress test. And what you're looking for is with the debunamine, you expect an increase in the contractility of the heart, and therefore, if the patient truly has a tight aortic valve, the gradient should increase. So in patients who have a low flow, low gradient aortic stenosis with the debunamine stress test, if you see an increase in valve area with the debunamine stress test, in that case, you have likely either a mild or moderate aortic stenosis, and this valve is not truly stenotic. Replacing a valve in this patient is unlikely to make a difference because the main problem is the ventricle itself. On the other hand, if you have no change in the valve area, however, the gradient across the valve increases, then this is likely to be a true severe aortic stenosis, and that group of patients would benefit from surgery. However, if you have a patient whose stroke volume fails to increase with the debutamy, then that means that this ventricle is extremely weak and extremely sick, and this is a group of patients that will have the highest risk of mortality. But having said that, typically patients with a low ejection fraction, but who does have a high gradient, will generally improve with surgery. One study from 2001 looked at this group of patients with low flow, low gradient aortic stenosis, and the mean ejection fraction was 29% in these patients, and the gradient was low, 26, much less than what the cutoff is for severe aortic stenosis. And these patients were giving debutamy. And what was found is that those patients who did have contractile reserve, where the stroke volume increased, these patients did much better in surgery than those patients who did not have a contractile reserve. Balloon valvuloplasty was also developed and did show some initial promise. However, patients, although they had symptomatic release early, with the increase in valve area, tend to restenose very quickly within 6 months, and the overall survival was no different. This is now mainly done in patients who are very ill and who are not otherwise surgical candidates, and you're trying to determine whether or not their aortic valve is truly the main problem or not. And this is still done, but very infrequently in these very high-risk group of patients. Lastly, I want to talk about small aortic root patients. So consider these two patients. The first patient is a 56-year-old female who's very active, but who's quite obese and has a weight of 110 kilograms with a normal ejection fraction. And the valve size may only be 19 millimeters. You can have another patient who's an 80-year-old female who may be much smaller, and less active. And although these two patients have the same valve area and the same valve annulus area, these two patients will do dramatically different if you place the same size valve for the patient. Whereas the second patient will do fine with just a very small valve. The first patient, if you put in a small valve, that valve may not be sufficient for that patient. So for both of these patients, we can calculate something called the body surface area based on their height and their weight. And using the body surface area, we can predict which patient will develop what we call patient prosthesis mismatch. And that is if you have a large patient, but you have put a small valve in, even though the valve is no longer stenotic, that valve may still be too small. And for each valve, each type of valve, you have standard sizes that are available for that type of valve. And each one of those valves, for each size, you know the effective orifice area based on the calculation of the valve area. And you know for the patient's body surface area, you can predict which patient will develop patient prosthesis mismatch or not. So patients who do have severe ventricular hypertrophy, putting too small of a valve do lead to a worse outcome over time, and that difference is intensified in younger patients. So in the younger patients, we do want to put as big of a valve as we can for these patients, and we'll be a lot more aggressive in performing root enlargements so that we can put in bigger valves for bigger patients and younger patients. So to summarize, for these two patients, the first patient will likely do a root enlargement so we could get a bigger valve in, and we want to put in a 23 to 25 millimeter valve, versus the second patient will do just fine with a small valve. Also, bicuspid aortic valve is something that's quite common. It happens in about 1 out of every 50 people, and you can have two types of bicuspid valve. One is what we call the conjoint bicuspid valve, where two of the leaflets are joined by a fusion of the commissures, and much more rare is the true bicuspid valve, where you have two leaflets that are symmetrical. With bicuspid valve, often you have aortic valve stenosis, and these patients can present with aortic stenosis. In these cases, the valve is unsalvageable and you have to replace the valve. However, there are other types of patients with bicuspid valve who comes in with normal leaflets, but who have severe aortic insufficiency. In these cases, the valve can be salvaged and can be repaired. The key here is that you want to create two fairly even valves and fairly even in length, and the conjoint cusp often is longer than the other cusp, and that valve had to be plicated in the middle so that the length of these valves match. We then also put commissural stitches to bring in the commissures to reduce the tension on the leaflets, as well as put in figure of 8 stitches at the commissures to hitch up the attachment points of the valves to make the valve coapt better. Bicuspid valve patients also have associated aneurysms, and using machine learning, we identify 3 patterns of aneurysm. The first pattern is an aneurysm of the aortic root. The second pattern is mid-ascending, and the third pattern is in the aortic arch. And those patients who have aortic aneurysm should have their aneurysm repaired at the same time. We do 3D reconstruction for all these patients to get a true measurement of their aortas in all locations, and we'll tailor their operation accordingly. So patients with bicuspid aortic valve at our institution, if they have a normal working valve, often will get aortic valve repair. If they have normal root as well as ascending aortic replacement, including a root replacement or hemiarch, depending on where their aneurysms are. And this is a very good operation that's very durable over time with a low mortality and the good durability. The gradients after aortic valve repair does increase over time. However, remains low in a lot of these patients. At 15 years, the gradient is still only about 20, which is still would place these patients in the mild range. And the re-intervention need for re-interventions is low in these patients. And also, when these patients do need re-intervention, it is relatively a straightforward operation to replace bicuspid valve with a root aneurysm, we will perform what's called a David's procedure or root implantation procedure, where the aorta will be removed. However, the valve will be spared. The aortic root will be replaced with a graft, and patient's own aortic valve will be reimplanted into the new graft, and the coronary arteries would then also be reimplanted into the new valve. And you would end up with something looking like this, where you have two leaflets that are now symmetrical. The conjoint cusp has been plicated so that the free edge of the leaflets match in length, and the entire root has been replaced with a graft. So in conclusion, consider aortic valve replacements in asymptomatic patients. Left ventricular hypertrophy is not a benign process, and when this is seen, these patients should go for surgery. Bioprosthetic valves are prostheses of choice for the majority of patients. The size of bioprosthesis does not tend to matter for older patients, but in younger patients, you want to put as large of a bioprosthetic as you can, often requiring root enlargement. And every patient with severe aortic stenosis to see a surgeon. Now, there are groups of patients who may just be too high risk for surgery, and the transcatheter valves were developed for this group of patients. Now, in this part of the presentation, I'll talk about who should be considered for a TAVR, what are the treatment options, what are the valves that are available, and the approaches, what are the expected outcomes, and some of the newer devices, and what are the current indications. So the current indications for TAVR is that it's rapidly becoming the standard of care for symptomatic patients with severe aortic stenosis who are not previously considered candidates for open surgery. As well, in patients who are considered high risk for open surgery, and that is defined by a STS mortality of greater than 8% or operative mortality of greater than 15% as assessed by a cardiothoracic surgeon or an interventional cardiologist. These are considered high risk patients for open surgery, and TAVR is appropriate for them. So looking at the spectrum of various patients, you have the low risk patients and the intermediate patients. And these patients are best approached with the open surgery. The high-risk patients or the inoperable patients are best approached with TAVR. And truly, the inoperable patients and very frail, very elderly patients should not receive anything, and as these are likely going to be futile. For evaluation of a patient for TAVR requires a multidisciplinary approach with a multidisciplinary heart team. This is our heart team, including surgeons and cardiologists and radiologists, as well as nurses and social worker. And it does truly require a full team to evaluate these patients to see if they're appropriate for one approach versus the other. When we evaluate patients' risk of surgery, we're looking at their predicted mortality with open surgery, and we use the STS score. In low-risk patients, these are patients with a predicted mortality of less than 4%. These patients are undergoing open surgery. In intermediate-risk patients or patients with a risk of 4 to 8%, most of these patients will still undergo open surgery, but there are clinical trials that are enrolling these type of patients between open versus TAVR operation. In high-risk patients, and some centers, these patients are still offered open surgery, but this is dependent, and only the best centers with the best outcomes will take these patients for open surgery. In other centers, these patients are undergoing TAVR, and the extreme risk patients, or those with a greater than 15% risk of mortality, in most centers, these patients are either undergoing TAVR or being managed medically. What are some of the features that would predict a high open surgical mortality? You have patients who have a heavily calcified aorta that would present a high risk of a stroke with a clamping of the aorta. You can have patients who have a hostile chest, either with previous radiation or have a deformity, or who have a previous coronary bypass with a graft that are close to the sternum that would be at risk on reentry. Patients with severe chronic lung disease, liver disease, pulmonary hypertension, dementia, and also patients with low ejection fraction without contractile reserve. We also evaluate patients' functional assessment, which the frailty predicts outcomes at 30 days. And there are various tests that we can use for frailty. We're also looking at the patient's the diagnostic studies involving the echo, their CT, and the catheterization to look to see whether or not they need any adjunct procedures, as well as their functional studies for their pulmonary, their carotid, as well as a stress test to assess functional capacity. And when you have all this information, we amalgamate the risk together to have a global risk for the patient. So for the surgical risk, anticipated benefit of TAVR, and then the team will then decide whether or not a patient is appropriate for a TAVR. Some of the anatomical planning requires a radiologist to help us with the evaluation of these patients. We will measure the aortic valve and also look at the position of the coronary arteries in relation to the aortic valve to help us identify which valve may be the most appropriate to avoid any impingement on the coronary arteries. We're also looking at the size of the roots, as well as the angle of the roots, as well as access. So these devices are preferentially inserted through the femoral artery. However, not all femoral arteries are large enough. Cases are done in a hybrid suite with the presence of both a surgeon and a cardiologist. And this is the typical setup. The device is inserted through a femoral arterial sheath. We have a second arterial sheath placed for pigtail and a contralateral wire, and we also have venous access for ventricular pacing. We can insert a pacemaker wire through the venous access to pace the heart so that the valve doesn't get ejected. To perform the TAVR, we first perform an aortic root injection. This gives us a good idea where the annulus is, as well as where the coronary buttons are. Next, a balloon valvuloplasty is performed, and this essentially would break the aortic valve and push the aortic valve tissues aside and give us a nice conduit for the device in deployment. The device is then inserted and brought across over the aortic arch over a stiff Lunderquist wire. And finally, the device is deployed. And this is the cosmesis afterwards. Traditionally, the TAVRs are performed transfemorally. However, there are patients whose transfemoral access is just not adequate. For example, patients who have peripheral vascular disease and patients who have small iliac arteries. So in these patients, alternative access is needed through a variety of other approaches. Over time, the devices have become smaller and smaller, and the need for the alternative access has decreased. But when alternative access is needed, what we can do is place the device directly through the apex of the heart, called the transapical approach, and this requires a mini left-sided thoracotomy. Also, the device can be inserted through the subclavian artery or the carotid artery, or directly from the ascending aorta through a mini hemiupper sternotomy. At Cleveland Clinic, transfemoral approach represents about 78% of all TAVR procedures, and this was data that was prior to 2015. And with the newer generation of devices with a smaller sheath, this transfemoral approach has become even more common. This is a diagram of the transaortic approach. This can be done either through a mini hemiupper sternotomy or a second intercostal space exposure, and the device will be deployed directly from the aorta through a purse string in the aorta. Transapical is also possible. This is a small lateral thoracotomy, and a purse string is placed in the apex of the heart, and then the device is deployed through the apex. Subclavian is also possible. However, this you need to make sure that the patient has suitable size subclavian artery. Transcarotid has also been described, but we have not done very many with this approach, as it is rarely needed. So looking at the partner trial in a high-risk patients who received a TAVR versus medical management, these are truly the high-risk patients. You can see that in this group, patients who received TAVR did substantially better from both a mortality and a morbidity standpoint. And in a five-year outcome, the patients with the TAVR had a better survival as well. Again, this was in a group of patients that had inoperable aortic stenosis. Now looking at the Partner 1A trial, where this was high-risk patients who were randomized to standard open heart operation, or SAVR, versus TAVR. You can see that in this high-risk but still operable patient, the patients did identical, regardless of if they received a surgical AVR or a TAVR procedure. And the mean valve area remained the same over time. This is with another device with the core valve, and in the core valve trial, the TAVR in a high-risk group, in fact, had a slightly less mortality compared to the surgical group. So looking at our Cleveland Clinic experience, we have a 30-day mortality with TAVR that is only 0.4%, which is even less than what's been printed in the manuscripts and what's in the large series. Our stroke risk for TAVR is approximately 2%. Vascular complication rate is about 9%, but that is decreasing with the smaller devices. And major bleeding requiring transfusions has also been around 5%. The 30-day mortality, looking at the various trials, in the early trials in Germany and France were around 10%. In the Partner 1A and Partner B trial, there was around 3 to 5%. And our experience, in the first 255 cases, the mortality was only 0.4%. So this is a diagram showing the decrease in size of the sheath. And in the first generation devices, the Cribier-Edward device in 2002 had a 24 French sheath. And in the newest Sapien 3 device, it's only a 14 French, which means a lot more of these patients can be accessed transfemorally, which is the preferred approach for these patients. Some of the advantages of the newer devices, like the S3, these devices have a skirt at the bottom of the device, which helps seal the device better and has a less risk of paravalvular leak. Now, looking forward, there are still obstacles for the TAVR technology, and some of the obstacles include paravalvular leak, stroke, heart block, vascular complications, and coronary occlusion. So some of the newer valves are designed to alleviate some of these complications, and the Evolute Art device has a seal zone that goes lower into the ventricle, and that decreases the paravalvular leak. The Lotus system is a different platform, and the direct flow is also a different platform or devices. And all the new devices, the goal is to overcome some of the complications associated with the early generation devices that I've previously alluded to in the last few slides. Now, overall, looking at the paravalvular leak per se, we know paravalvular leak is directly associated with the long-term durability and survival for these patients. So as these devices improve, it is imperative that the paravalvular leak decreases. And we have shown over time through the various iterations of the devices and the new generation devices that the percentage of patients who have moderate or severe paravalvular leak continues to decrease, and currently is only around 1 to 3% with the newer generation of devices. So now, in terms of a stroke prevention, because you're not removing the device per se, and rather just pushing the valve, the patient's old valve to the side, there is a higher risk of embolic disease. And there have been some devices that have been invented to address this problem and to capture potential debris, such as the Claret device. And this is an example of the type of debris that has been captured by this device. The other major issue that has been brought to light is the possibility of a leaflet thrombosis. And although with the biologic valves, it is uncommon for us to anticoagulate these patients, this is something that needs to be followed very closely for these patients. And some of these patients may benefit from systemic anticoagulation for a period of time. In patients who have a previous valve replacement, and undergoing redo surgery, if these patients are older and higher risk, you can perform a valve-in-valve. You can place one of these TAVR devices inside a patient's previous bioprosthetic valves, and that's something that continues to be done and works quite well. Now, I want to shift gears a bit and talk about the role of balloon valvuloplasty. There was early enthusiasm for balloon valvuloplasty. However, you can see that over time that the balloon valvuloplasty does not seem to have a durable effect, as the patient's aortic stenosis comes back quite quickly. And really now, currently, the role of balloon valvuloplasty is either just to provide the patient with some temporary relief from their aortic stenosis, and also just to test the patient to see whether or not they may benefit from a TAVR before you undergo the TAVR procedure. Currently, the balloon valvuloplasty has really fallen out of favor, and it's only used a very small subset of patients who are too high risk for TAVR or open surgery or even TAVR. So just to summarize, when is surgical operation a better option for these patients? In cases, certainly when you have an infected valve, when you have endocarditis, surgery will always provide a better outcome because you can go in and remove all the infected valve and all the infected tissue. You do not want to put a device that's into an infected space. There are some technical considerations. Sometimes you have a patient who has a too small of an annulus or too large of an annulus for TAVR, and the surgical operation would be better for these patients. Also, patients with bicuspid aortic valve, the geometry of the annulus may be too elliptical, and you may have a better outcome with the surgical operation. Patients also can have a coronary ostia that are very low relative to the annulus, and you worry about possible coronary occlusion with the TAVR devices. Some patients with pure AI, in fact, most patients with pure AI will do better with a surgical operation, because these patients do not have significant amount of calcium. It can be more difficult to seal the devices. And also in the other extreme, when you have patients with too much calcification, particularly at the level of the sinotubular junction, surgery may be a better option for these patients. Also, finally, patients who have a concomitant severe mitral regurgitation or coronary disease, although may be addressed with PCI at the same time as TAVR, these patients, if they require multiple other interventions on the heart, may be best addressed with surgery. When would you want to do a TAVR on a patient who have a much longer life expectancy, such as a young patient? In general, the longer the patient's life expectancy, the more you should consider surgery, because right now, although we do have quite a bit of evidence, we still don't have a very good long-term durability evidence of these devices. So currently, if patients are young and we expect that they would have a long life expectancy, we do tend to favor open surgery, even if they have a higher risk. So the key to a successful program and having good outcomes and low mortality is really to have a collaborative approach between surgeons and cardiologists. Both teams will evaluate these patients. There's a co-leadership structure for these programs, and with a continuous open communication, early conflict resolution, you want to build a consensus on which patient is best approached with either technology. And you share the resources and credits, and those are all key in terms of having a good outcome. So just in conclusion, TAVR is an expanding and rapidly becoming the preferred treatment in some patients with the highest surgical risk. The use of TAVR is now increasingly common in intermediate and even in some lower risk patients with early results similar to surgical AVR, but long-term results are still pending. Post-procedure aortic insufficiency is improving with the newer generation devices, but has still not been fully resolved, and further studies are needed to identify anatomic subsets of patients who will benefit the most from TAVR versus surgical AVR. So, and now in terms of the guidelines, when you have a patient with a symptomatic aortic stenosis, if they have low surgical risk, these patients should undergo surgical AVR. If they have an intermediate risk, you have a class 1 indication for surgical AVR and class 2A indication for TAVR. In high risk, you have class 1 indication for both surgical AVR or TAVR, and in patients with a prohibitive surgical open surgical risk, and then these patients have a class 1 indication for TAVR. So now I'll skip to the next chapter of my talk, and with the mitral valves. So I'm going to be talking about the anatomy of the mitral valve. I'll be talking about degenerative mitral valve regurgitation, ischemic mitral regurgitation. I'm essentially going to skip mitral stenosis because it's something that we see less and less now as the rheumatic disease is becoming less prevalent, and also talk a little bit about the surgical approaches. So in terms of the anatomy, the mitral valve is a valve that is not just the leaflets alone, but contains many other structures, including the fibroskeleton of the heart, where the mitral valve is anchored onto. You have the actual mitral annulus itself. You have the mitral leaflets. You have the cords that anchor the mitral valve leaflets to the left ventricle, as well as the papillary muscles. And it's important to understand and appreciate all of these factors when you're evaluating a patient who has mitral regurgitation and trying to figure out whether that valve is repairable or needs to be replaced. So this is how the mitral valve is anatomically designed. You have a valve that separates between the left atrium and the left ventricle. You have primary cords that anchor to the free edge of the leaflet, as well as secondary and tertiary cords that anchor to the base of the valve, as well as more to the annulus itself. The mitral valve on the anterior side is anchored onto the trigone. You have a fibromuscular structure which have the left and the right trigone, and this fibromuscular structure is also shared with the aortic valve annulus. Between the mitral valve and the aortic valve, you have the aortomitral curtain, which is a fibrous structure, and this is a structure that's very important when you're replacing mitral valves, because you need to get your sutures onto this fibromuscular structure in terms of in order to be able to get the good support for the valve. The anterior leaflet, although is only anchored to about a third of the entire circumference, does take up about 2/3 of the total area of the valve. It's also important to understand that the mitral valve is not a planar structure, but a three-dimensional structure, and has a shape of a saddle, where the middle part of the valve is higher than the two sides of the valve. So looking at the surrounding structures, you have the anterior leaflet, the mitral valve, and the posterior leaflet. You can see that the circumflex artery does come quite close to the mitral valve. And in patients who have a dominant circumflex, when you do mitral valve surgery, if the stitches go too deep into the annulus, you can end up injuring the circumflex artery, and you can have a perioperative myocardial infarction. Also on the right side of the posterior annulus, you have the coronary sinus, and on the anterior aspect of the valve, this valve comes in close proximity to the aortic valve. So stitches along the anterior annulus of the anterior leaflet, if gone too deep, can also injure the coronary cusp of the aortic valve. So you have, for mitral regurgitation, you have classification of mitral regurgitation, and this is based on the Carpentier classification. So type 1 is a functional regurgitation, where you have a normal leaflet structure, and you have a leak that goes in between the leaflets. Type 2 is when you have excessive leaflet motion. So the mitral valve leaflets are not coapting at the normal zone, and one of the leaflets in fact ends up at a higher position. You can see this with the mitral valve prolapse or with a ruptured cord, where the mitral valve leaflet or one of the mitral valve leaflets or both end up higher than the coaptation plane, and you end up with mitral regurgitation. Type 3A and type 3B are restricted leaflet motion, where the mitral valve leaflets end up becoming pulled down, and that can also lead to regurgitation if the leaflets are being pulled down onto the ventricle and not allowed to coapt. And type 3A is during systole, type 3B is during diastole, when you have ischemic mitral regurgitation with a very large ventricle that ends up pulling the cords down towards the base of the ventricle and prevents the leaflets from coapting. Now, looking at degenerative mitral valve, most of these cases can be repaired in about 95% of cases, and this can be done through a number of various techniques. And essentially, these 5 techniques will allow you to repair about 95% of mitral valves. And this is a triangular resection with neocords, sliding plasty, annuloplasty ring, and a commissural stitch. So the most common type of degenerative mitral regurgitation is posterior leaflet prolapse, and this can be addressed through a triangular resection. I'll show you some diagrams in the upcoming slides. You can also, if you don't want to resect the valve leaflet, you can place artificial cords to pull the leaflet back down to its normal position. And when you have a large area of a prolapsing leaflet that you need to resect, you may need to reconstruct with a sliding plasty. When it comes to anterior leaflet prolapse, the best approach is with the artificial cords. And for all mitral valve repairs, most of these patients will benefit from an annuloplasty to support the annulus. So this is an example of a triangular resection. You have a patient with a posterior leaflet prolapse. The cord here has ruptured, and this part of the valve is prolapsing or flailing. And you can then perform a triangular resection, getting rid of the posterior annulus associated with that's tethered by this cord. And then you just suture the rest of the leaflet together, and you support with a ring or a band. Now, some of the considerations for mitral valve repair is some of these patients, if you resect too much of the leaflets, then you may end up with something called a systolic anterior motion, or SAM for short. And in these patients, typically the type of patients where you'll see this are patients with either a very large posterior leaflet or a very small hyperdynamic left ventricle and a narrow left ventricular outflow tract. And the risk of SAM becomes particularly excessive when you do an extensive resection in these patients. So here's an example of to get around this risk of SAM. What you can do is something called a sliding plasty. So you would cut out the part of the leaflets that is flailing, and because in this case you are cutting out quite a bit of leaflet, when you just bring these leaflet together, it's if you have a very tall leaflet, such as this case like this, you're going to end up with a higher risk of systolic anterior motion. So to address this, we would do something called a sliding plasty. So sliding plasty, once the leaflet is resected, would detach the leaflet from the annulus on both sides like this, and you would put your annular stitches in. You would then bring the leaflets back together, and when you detach the leaflets, you would also cut out some excess leaflets just to shorten the height of the leaflet, and then you would resuture the leaflet back together. So now if you look at the original leaflet, you have a much higher leaflet, and post the repair, you're going to have a much shorter leaflet. By having this shorter leaflet, the coaptation ends up becoming more posterior and decreasing the risk of SAM, or systolic anterior motion. That's what the end result would look like. So for anterior leaflet regurgitation, most of these, there's been various techniques that's been described, and the two that are most commonly used right now are artificial cords with Gore-Tex cords, or with a chordal transfer where you take part of the cords from the posterior leaflet and transfer to the anterior leaflet. Artificial cords are probably easier to do, and this is what is used most commonly. So to create the cords, you can use calipers to measure the length of normal cords on the anterior leaflet, and then you can create the new cords that are at the measured length. And you can use a plugget with a Gore-Tex stitch, and using the calipers, you can create a new cord that is exactly at the length that you've measured. So the papillary, the plugget will be anchored onto the papillary muscle, and then leaving you a loop of cord, or you can have multiple loops of cord that is then anchored onto the free edge of the anterior leaflet. So sometimes once you've done the repair at the corners or at the commissures, you can still have a bit of a leak. And in these cases, you can just suture up the commissures and get rid of the leak, and that's called a commissoplasty. And finally, annuloplasty is absolutely needed for all patients undergoing mitral valve repair, and this is having an annuloplasty is a predictor of long-term durability. So in summary, for degenerative mitral valve disease, the valve is repairable in nearly all patients. So a minimally invasive approach can be used for these patients. This is a very low-risk operation with a mortality that should be less than 1%, and then high-volume centers can be even less than 0.5%. This is a very durable surgery with an excellent long-term outcome and has an excellent long-term survival. So ischemic regurgitation is a different animal, unfortunately. And with ischemic regurgitation, what you have essentially is the leaflets are normal. The leaflets are not torn. The cords are not torn. There is no prolapse of the leaflet. However, it's mainly a ventricular disease. If you have a ventricle that's too dilated, such as this, or you have a patient who had a myocardial infarction, and you have a papillary muscle dysfunction, this ends up in effect pulling the leaflets down, and what you have is regurgitation due to the fact that the subvalvular apparatus is not functioning well. This is most commonly seen when you have ischemic cardiomyopathy or dilated cardiomyopathy, where the ventricle is not working properly. In patients with coronary disease, about 10% of these patients will also have mitral regurgitation. And the reason for you get mitral regurgitation in these patients is multifactorial. In general, the predictors of ischemic mitral regurgitation that leads to heart failure are the extent of myocardial ischemia. The more myocardial ischemia you have, the less the ejection fraction, the more we're going to have heart failure in these patients. Also, the degree of MR, the more MR, the more heart failure, and also if you have the lower ejection fraction and the greater degree of ischemia, that's all associated with heart failure. So the key points when it comes to ischemic mitral regurgitation is that you don't have any mitral valve pathology itself. The mitral valve, if you're looking at the valves themselves, they look essentially perfect, and it's important to remember that it is just a ventricular disease that's the main trigger of this. So with that in mind, the treatment that you offer these patients, you should think of it more as a ventricular treatment. You want to treat the ventricle in order to get the MR better. Having said that, it's not always possible to treat the ventricle. Sometimes these patients do not have adequate targets for revascularization of their coronary disease, or they've already infarcted their territory. They've already infarcted their left ventricle, and that ventricular function may not come back. So nevertheless, these patients can still benefit from a mitral valve surgery alone. In these cases, when the goal of surgery is to improve their symptoms and to improve their exercise tolerance. By getting rid of the MR, you can possibly prevent further deterioration of their ventricular function. But most of the cardiac surgery literature suggests that you are not going to be improving the overall survival of these patients by operating on their ischemic MR. So when you look at the pathophysiology of ischemic MR, it really starts with a left ventricular injury, such as a myocardial infarction, that leads to regional wall motion abnormalities that will then cause the left ventricle to dilate. The left ventricle will become more spherical as opposed to conical. And from there, you're going to have papillary muscle dysfunction. The leaflets are going to be pulled down towards the ventricle, and you're going to have a poor coaptation and more apical tethering, and which also then leads to the annulus dilation. So when all these factors will come into play together, or in various combinations, that's what's going to lead to the mitral regurgitation for these patients. Ischemic mitral regurgitation carries generally a poor prognosis with a 5-year survival less than 50% if left untreated. PCI is often not an effective treatment for these patients. CABG alone often does not entirely correct the ventricular function, and hence will not reliably correct the mitral regurgitation. The surgical outcomes of CABG and the mitral valve repair or replacement overall have gotten steadily better over time as we're better at selecting these patients, but still carry an operative mortality of about 3 to 8%. Whether or not these patients are left with a residual mitral regurgitation does impact their survival. So the more residual regurgitation you have for these patients, the worse their outcomes. And untreated mitral regurgitation or untreated ischemic mitral regurgitation does significantly increase the hospitalization for congestive heart failure for these patients. So there's an early study from the 1990s published in Circulation that shows that in patients after a myocardial infarction, the more regurgitation you have, the worse your overall survival. And this is something that we've seen time and time again, but has been observed for decades now. The goal when you're operating on these patients is that you want to achieve either no residual regurgitation or at most mild regurgitation. So because the ventricle cannot always be altered in these patients, you are limited to options addressing just the annulus. The key to successfully repairing these valves is that you have to use essentially a full ring that's undersized. So if the patient has a very dilated annulus, you have to downsize that annulus, reduce the size of that annulus to be able to achieve leaflet coaptation. We tend to use rigid rings for this type of operation as opposed to flexible rings, and we tend to choose rings that have a saddle shape that will create more of a natural geometry for post-repair for these patients. So here are some of the techniques. We basically want to anchor your stitches onto the fibromuscular skeleton of the mitral valve, and then you're putting in an undersized ring to reduce the size of the mitral annulus to allow for better coaptation. So the question of what to do with moderate ischemic MR has been debated, and there was a recent study looking at this. So when it comes to moderate ischemic regurgitation, in this study, patients had either a CABG alone or a CABG with a mitral valve repair. And the mortality, this was a fairly recent study, the mortality in this group was fairly low, was only about a 2% mortality, But at 1 year, there was a 7% mortality, which means a lot of these patients, even though you could get them surgery, many of these patients can still die from their disease because of their cardiomyopathy. CABG alone, the group that had CABG alone had a shorter cross-time time and a shorter hospital stay. And overall, patients who had a CABG and mitral valve repair had less moderate to severe mitral regurgitation 1 year at 12 months. And it was only about 11% in the mitral valve repair group and up to 31% in the group that had CABG alone. However, if you look at the hard outcomes, whether you repaired the mitral valve or not, there was no difference in survival, symptoms, or the quality of life in these patients. And looking at their NYHA class, there was also no difference between the CABG alone or the mitral valve repair group. There was some other studies that looked at the size of the left ventricle, and the size of the ventricle does predict outcomes. The larger the ventricle, the worse their outcome. And in this one study, it showed that a cutoff of a left ventricular end diastolic dimension of 65 millimeter as a cutoff were greater than that, you will have a decreased survival long term. Now, for severe ischemic regurgitation, it's also been debated what is better, to repair the valve or to replace the valve. Because this is a ventricular issue and not necessarily just a mitral valve issue, if you repair the valve, even though you can get the valve to look good at the time of surgery, long term you still can have progressive left ventricular dysfunction and the valve may continue to leak into the future. So looking at mortality alone at 12 months, there was no difference between the mitral valve repair or replacement group. However, early on, there was a survival advantage in the mitral valve repair, but overall, this was not statistically significant. Looking at the functional improvement in these patients, both groups had improvement in their functional status. They felt better, and there was no difference between the repair and replacement. But the important thing was that a recurrence of moderate or more mitral regurgitation at 12 months was only 2% in the replacement group, but 32% in the repair group. So in summary, if for ischemic mitral regurgitation, this is not a mitral valve pathology, but rather a left ventricular dysfunction. So you really want to try to address the left ventricular dysfunction itself, and that is going to be done through coronary artery bypass if you have suitable targets. Ischemic MR carries a poor long-term prognosis. Residual MR after repair is correlated with worse survival. If you are going to repair the valve, you want to downsize the annulus using a rigid ring. And once you can correct the MR, this may promote LV remodeling and prevent the patient ventricle from getting worse into the future. There's increased evidence that replacement might be better than repair with ischemic MR, but overall for this group of patients, there are still many unanswered questions that we'll continue to explore. I'm just going to touch a little bit about mitral stenosis, and mitral stenosis is primarily seen in a rheumatic heart disease, and there has been some papers describing stripping away the scar of the mitral valve to allow for better coaptation and better leak flow motion. However, this is not a durable repair, and for most of these patients, it is best approached through a mitral valve replacement. Now, for time's sake, I'm not going to go into too much detail, but in essence, when you have mitral valve stenosis, most of these patients will have a mitral valve replacement. Now, surgical considerations for mitral valve surgery. Traditionally, these cases are done through a median sternotomy. However, there have been less invasive approaches that have been beneficial for patients, and I'll go into the hemi-upper sternotomy, the lower hemisternotomy, right thoracotomy, and robotic approaches. So a hemi-upper sternotomy can be done through a 6 to 8 centimeter incision in the top part of the sternum. You would perform the sternotomy down to the fourth intercostal space and bring it out from the right side, dividing the sternum in the fourth intercostal space on the right side. And with a retractor, you can have excellent visibility to the aorta, to the right atrium SVC, and this will allow you to get to the mitral valve. So this is the incision, and this is the exposure. You would do a transeptal approach where you would open up the right atrium and carry it onto the roof of the left atrium. Once the right atrium is open, you can see the foramen ovale. You could then open the atrial septum into the roof of the left atrium to give you exposure in the mitral valve. Once the mitral valve once your septum is lifted up with the retractor, you should be able to have good visualization to the mitral valve itself. This is the exposure that you can get. You would then proceed with your repair stitch of choice. And then when you finish, you close up the atrial septum and you close up the right atrium. And then you can still have access to the heart to put your pacing wires on both the ventricular and the aortic side. And this is the final cosmesis afterwards. And this is a live example of the type of exposure that you can get through this approach. As you can see the entire leaflet and the entire valve through this approach, and is generally a fairly reproducible technique. And this is the final cosmesis. Right thoracotomy is also a very popular approach. This can be done through a small costal incision, and typically in the fourth space, but you can do a chest CT to figure out exactly which intercostal space will give you the best approach. Over time, this incision has even come down, and can often be done through a 4-centimeter incision. You have soft tissue retractors that can bring the fat and the muscle away. And with a retractor, you can get into the right pleural cavity and give you access to the pericardium and to the right side of the heart. Patients will be put on cardiopulmonary bypass from the femoral artery and the femoral vein. And often you can either do this through direct vision or through a scope that could give you visualization to the heart. The aorta can be either cross-clamped with a balloon clamp called the endoballoon, or you can place a clamp directly from the chest wall and clamp the aorta directly. You also have a cardioplegia cannula that can be inserted onto the ascending aorta for the delivery cardioplegia. And this is the exposure that you can get, and the exposure is typically quite good. Along the same lines, if you want to reduce the incision even further or have a percutaneous approach, this can be done through a robotic approach. And with the Da Vinci robot, you can have excellent visualization and an excellent control. You would have a small service port incision. Fourth intercostal space is typically what's used. And then you also have another port for the camera insertion. And this is what the exposure looks like. You have your two working ports, the left and the right. This is the center port for when you're inserting the device, and the camera port is up here. And this is the final cosmesis afterwards. So over time, the mitral valve surgery or isolated mitral valve surgery, particularly degenerated mitral valve, the field has progressed from a median sternotomy to a mini thoracotomy to possibly even a totally endoscopic robotic approach. And over time, the invasiveness of this operation has decreased. And in cardiac surgery, this is probably the single greatest benefit of this surgery, represents the greatest benefit of using robotic technology, because it truly gives you excellent visualization and excellent outcomes. So now looking at the guidelines for mitral valve surgery. So when it comes to primary MR, when MR is the main problem for the patients, you first want to know how bad the MR is. If the patient has severe MR and they're symptomatic and they have a reduced ejection, when they have a normal ejection fraction, so symptomatic severe MR, these patients have a class 1 indication for surgery. When when these patients have a poor ejection fraction less than 30%, surgery is less well established. These patients will tend to feel better after surgery, but typically you will not necessarily see a survival advantage. That's why you only have a class 2B indication in patients with a symptomatic MR but with a low ejection fraction. Now for asymptomatic disease, it's a little more complex. If you have an asymptomatic MR but have a decreased ejection fraction, you should still have surgery. If a patient has a normal ejection fraction, but they're asymptomatic, and you see a continued enlargement of the ventricle, you have a 2A indication. But if you have a small ventricle, and asymptomatic with a normal ventricle, but you feel confident that you can repair the valve, you should still undergo a repair with a class 2A indication. And this really comes to what the skill set of the surgeon is and the skill set of the institution. And this is the advantage of being a high volume institution. If you feel that you can have a good repair and a high success of repair, these patients should undergo surgery. If you're at a center that does not do a lot of mitral valve and you do not feel confident that you can successfully repair these valves, either send these patients to a high volume center or periodically monitor these patients on a regular basis and operate on them once they become more symptomatic. When it comes to secondary MR, so this is a more ischemic MR that's caused by coronary disease and such. If these patients are symptomatic and they have symptoms, these patients should still undergo surgery, but it is less well established the benefit of surgery. You're going to likely have an improvement in symptoms, but you won't necessarily have a survival advantage. If these patients are asymptomatic, then it would be more appropriate just to continue to monitor these patients until they become more symptomatic. Because if the goal of the surgery is to make them feel better, but they're asymptomatic, there really would be not much advantage undergoing surgery when you have secondary MR. So these are just the guidelines in text format, and these have been summarized in the slides. So now in terms of the choice of prosthesis, it's really the same consideration of prosthesis as aortic valve surgery. If you have a younger patient, you want to, typically the younger they are, the more you're going to be favoring mechanical prosthesis. The older they are, you're going to favor bioprosthesis. Having said that, a lot of young patients, it is reasonable to give them a bioprosthesis if they do not want to take Coumadin, and you understand that these patients will then need to come back in about 10 to 15 years for a redo operation. And if you can offer that at low risk, then it is reasonable to offer young patients a bioprosthesis. So next I'm going to talk briefly about tricuspid valve disease. We know that tricuspid valve disease is bad. This paper from Jack from 2004 shows that the more degree of tricuspid regurgitation you have, the worse the long-term outcome. Now, the tricuspid valve has 3 leaflets. You have the anterior leaflet, you have the posterior leaflet, and the septal leaflet. The septal leaflet, of course, is the leaflet that's adjacent to the atrial septum. And in tricuspid valve, the annulus of the septal leaflet usually stays fixed. When patients have a right-sided heart failure and the heart gets enlarged, typically the part of the annulus that enlarges is the part of the annulus attached to the anterior and posterior leaflet. And this is typically what you see over time with the volume or pressure overload of the right side. Would have a tricuspid enlargement, and it's the annular and the posterior, the annulus that's associated with the anterior and posterior leaflet that's going to be dilating. When you're repairing these valves, the goal of the surgery is to reduce the dilated annulus back to its anatomic shape, and do this with a rigid ring. Stitches are placed along the annulus, and these are then passed through a ring. So you see that in the ring, there's usually a gap, and this is because you have an AV node here, and typically you want to avoid taking stitches into the AV node or to avoid the risk of heart block. The two type of rings that are most commonly used are the Carpentier-Edward classic ring and the MC3 ring, both of which are rigid rings. Historically, tricuspid valve have also been repaired through just a stitch alone, called the Vega stitch, where you're taking a stitch into the posterior and the annulus associated with the anterior and posterior leaflet, and just using the stitch alone to bring the annulus down, or using a pericardium. But you can see the durability of this type of repair with Paragard or the stitch is not very good, and this has typically been currently this has really been abandoned in favor of more of a rigid ring, which gives you a much more durable result. Also, the more preoperative TR you have, the higher the likelihood of a postoperative TR, which has also been shown. So often tricuspid regurgitation is a secondary issue, which means this is usually due to left-sided heart issues. So if you have a patient with the left-sided heart disease or left-sided valvular disease or coronary disease, this ends up causing patients to develop pulmonary hypertension, volume overload, pressure overload, which then puts pressure on the right heart. The right heart then starts to dilate. You have annular dilatation leading to TR. So the question has always, when it comes to mitral valve surgery, is should you repair the tricuspid valve at the same time? And this question was looked at by Vince Chan from Ottawa, and what the group did was looked at all patients who underwent mitral valve surgery, and looked at the patients that had moderate or more tricuspid regurgitation, and then looked at those patients who had a repair or replacement. Now, these were not randomized patients. This was retrospective, but nevertheless, it does provide some interesting conclusions. There was so with the greater the TR, you do see a difference in survival when you have patients who had a repair versus no repair. Certainly, if the patients did not have any TR at the beginning, they did the best. But those that had TR, it didn't seem to matter whether or not they had a repair or not. So in terms of the survival, it didn't matter. But in terms of freedom from congestive heart failure, it did seem to matter. Patients that had a repair of their TR had the same freedom from congestive heart failure as those patients that didn't have any TR, versus those patients that did not receive a tricuspid repair when they had 2+ or more tricuspid regurgitation. These patients had a higher incidence of congestive heart failure. So based on this, you can conclude that if you have moderate or more tricuspid regurgitation, the valve should be repaired. The repair won't necessarily make you live longer, but will make you feel better. And this seems to be the approach that most centers are taking. There's also another study more recently that's looking at the size of the tricuspid valve annulus as a predictor. And this is still debated whether or not a dilated tricuspid annulus with no tricuspid repair should be repaired at the time of mitral valve surgery, and this is something that we should know the answer in the upcoming years. So, in summary, tricuspid valve insufficiency does not necessarily regress over time, and does not necessarily regress once you fix a patient's left-sided heart disease. the tricuspid insufficiency will typically increase over time and adversely affect the right ventricle. Uncorrected tricuspid valve insufficiency is associated with poor long-term results and outcomes, and the greater the degree of TR you have, the worse your long-term outcome. Organic tricuspid valve insufficiency should always be repaired. And so if you only have tricuspid valve issues for these patients, you should repair. But when it's a functional regurgitation without that's associated with left-sided disease, typically we would repair it too once you have at least a moderate disease. And using a rigid ring team tends to be better than a flexible ring or just the sutures alone. And lastly, I want to talk briefly about endocarditis. Endocarditis is a devastating disease, and here I'll talk a little bit about the medical management versus the surgical management. I'll talk about the difference between invasive and non-invasive endocarditis, some of the surgical principles regarding to endocarditis. Now, in many centers, endocarditis is still managed with medications and antibiotics alone, and the reason for that is because it's a big operation, and it's not a type of operation where you know exactly what you're going to see when you get in there. When you have endocarditis, you can have destruction of not only the leaflets but also the surrounding tissue. And if you're not prepared you're not prepared for reconstruction of the heart and the roots, you can end up with a situation where you may not be able to get out of the operating room. So this is a difficult problem to address surgically, and this is an operation where low volume centers may not be familiar to deal with. But nevertheless, we know that infective endocarditis is a fatal disease, and it's notoriously difficult to treat with medical management alone. In fact, we know that with medical management, the survival is very poor. At 12 months, with medical management, the survival is less than 50%. And with the more aggressive pathogens such as Staph aureus, the survival is even worse, and the drop-off is even more quick as you get rapid destruction of the perivalvular tissues of the heart. But with surgery, and with successful surgery, you can change the outlook for these patients. If the surgery is successful, these patients will do well long term. So the question really here is, it's not when you should operate on these patients or manage them medically. The real question really is, are you going to operate on these patients or let these patients die? There really hasn't been that many comparative studies, but there is this one RCT looking at early surgery versus conventional medical treatment for these patients. And they looked at 76 patients comparing conventional approach, which is starting with medical management, versus early surgery. And this is their distribution of patients. It's fairly evenly distributed. The valve involved was 60% times the mitral valve, 25 to 30% times was the aortic valve. In a handful of cases, they have both the aortic and the mitral valves were involved. And you can see that in terms of a probability of death, embolism, or recurrent infection, patients with early surgery did much better than conventional medical management for these patients. In fact, if you look at the outcomes for the conventional management group, you have 39 patients. 1 died, 27 eventually needed urgent surgery, and 11 patients were discharged. And out of the 11 that were discharged, 1 died, 3 also needed surgery. And the only patients that remained asymptomatic and successfully treated was only 3 out of 39, so less than 10%. So based on this study, our approach typically when we see infective endocarditis and the patient is otherwise strong enough to undergo surgery, we tend to offer patients surgery early. Now, the reason for this is when you have infective endocarditis, the disease undergo undergo a process of growth over time. First, you have the bacteria that attaches onto the valve. You then have a proliferation of the bacteria, but then the bacteria would often develop a layer of biofilms, making the antibiotic extremely difficult to penetrate. The vegetation can then break off and cause a peripheral embolus, or it will break open and you have a dispersion of the bacteria throughout the body, leading to infected sites elsewhere in the body. The valve, the process not only destroys the valve and the cusp and the leaflets, but can also start to destroy the other parts of the heart, leading to heart block if it destroys the conduction system, as well as the muscle itself and the walls of the heart. So what can surgery accomplish? Well, in surgery, you're not only in removing the vegetation itself, but you're removing all affected and necrotic tissue and foreign material. You get rid of the biofilms, you restore the cardiac integrity, and you restore normal valve function. And therefore, you potentially can cure the patient. And you're also removing the source of embolus, which is often what kills the patient. If these patients can have strokes, they can have septic emboli to their other major organs. When should you absolutely go for surgery? Certainly when these patients have valve destruction to the point where they're getting heart failure, you should go to surgery. If these patients have sepsis that are unresponding, not responding to antibiotics, you need to go to surgery. When you have invasive pathology where the valve and the surrounding tissue is getting destroyed, you go to surgery. Prosthetic valves are notoriously difficult to treat with antibiotics alone. And when you have a prosthetic valve infection, these patients should definitely go to surgery. And a large mobile vegetation greater than 10 millimeters is also an indication to remove the risk of embolic disease. So we looked at our experience with infective endocarditis over a 10-year span, and about half of these were aortic valve, a third were mitral valve, and a sixth were combined aortic and mitral valve. The native valve endocarditis represented 40% of our population, and prosthetic valve represented about 60%. When it came to the mitral valve, native valve represented an even larger proportion. And you can see that when you have a native valve, you have tissue inflammation, you have vegetation that are growing, and this will lead to a destruction of the perivalvular tissue that you need to debride. And once it's all debrided, you want to end up with something like this, with a nice clean edges and all infected material completely removed. But when you have a prosthetic valve, because you have sutures in place, because the planes may be already destroyed by the valve itself, the degree of destruction is often a lot more severe and requires a lot more radical debridement for these patients. Nevertheless, when it came to the outcomes for the patients, you can get an equal outcome whether you have a native valve endocarditis or a prosthetic valve endocarditis. Now, when it comes to right-sided endocarditis involving the tricuspid valve, this is most often caused by IV drug use or dialysis patient, or patients who have a pacemaker or an ICD that gets infected because of the leads. When these patients have these infections, often they will get septic emboli to the lungs, and you could then develop a lung abscess. And really the indication for surgery when you have right-sided endocarditis is when you have large vegetation and you want to prevent them from having embolus, or they have severe tricuspid regurgitation with heart failure. When you have right-sided infective endocarditis, we prefer to repair the valve as opposed to replacing the valve, as repairing the valve will often give you a more durable result and more resistant to reinfection. Whenever we can, we'll use pericardium to reconstruct the valve, and although this may not be necessarily a long-term solution with a long-term durability, it does give you the opportunity to then send these patients with the IV drug use history to rehab, allow their heart to recover, allow them to come off of drugs, and at a later point you can then go back and replace the valve once the infection is fully resolved and the patient is the underlying cause for the infection is resolved. So some of the considerations for surgery when it comes to understanding the anatomy when it comes to endocarditis, understanding the anatomy is absolutely the most critical point. When you get in, not only is the valve destroyed in the aortic valve or the mitral valve, but often the structures around the valve are often destroyed as well, and these all need to be reconstructed in order to have a good outcome. So for these surgeries, we'll like to have antimicrobials already on board. These patients should be treated with appropriate antibiotics before you go to the operating room, so that you have circulating antimicrobials on board already. You want to understand what you're seeing. You want to have a really good understanding of the anatomy, and understanding what type of destruction you have and what are the surrounding tissues that may be destroyed. And the key here is a radical debridement. You want to take out any infected tissue, and only then can you get a good outcome. If you leave behind any infected tissue, the infection will come back. Once the infection has been fully debrided, then you construct the heart and the valves, and you want to allow any abscess to drain into the pericardium as opposed to back into the bloodstream. So this is an example of aortic valve endocarditis. The valve has been removed, and all the infective surrounding tissue has been completely removed. And we prefer to use a homograph for reconstruction of the aortic valve, as the homograph is a lot more resistant to infection, and also you have surrounding tissues with the homograph that will allow you to have to patch up any holes that you may have after you do debridement. This is what the outcome looks like. You're going to have, this is the abscess cavity you let to drain into the pericardium. So we looked at our experience, and the recurrence of infection is much lower with the homograph than with a mechanical or a bioprosthetic valve, and this is why we tend to use homographs when we for endocarditis surgery. Mitral valve endocarditis is more difficult to treat, and also these patients tend to do worse when you have mitral valve endocarditis that's invaded into the surrounding tissue. This is an example of a mitral valve vegetation. Often these infections will then invade into the surrounding tissues, and you need to patch the tissue before you put the new valve in. So in here you can see that we've reconstructed the annulus with the pericardium so that you restore the integrity of the atrium and mitral annulus. So in conclusion, when it comes to endocarditis, once there's an indication for surgery, operate. Don't sit on the patient. The sooner you operate, the better these patients will do. The leaky valves will not become competent on their own. Disintegrated tissue will not regrow, and the risk of surgery is high, but the risk of non-surgery is much higher. Therefore, if you have indication to operate on these patients. So this is the guidelines that Dr. Pedersen from Cleveland Clinic have come out with, and essentially when it comes to surgery, once a decision is made about surgery, it should be made in a multidisciplinary team with cardiology, cardiothoracic surgery, and infectious disease. Early surgery do better when you have a valve dysfunction and have heart failure symptoms. Once the indication is there, you come to the operating room. You want to have antibiotics on board that are appropriate for these patients and for their bugs before you take them to the operating room. And also, if you have evidence of destruction of the perivalvular structures leading to heart block, abscess, or destructive and penetrating lesions and holes inside the heart, That's also 1A indication. And also patients who have recurrent bacteremia with the recurrent evidence of sepsis despite antimicrobial treatment, that's also another indication. And whenever you have a patient with a prosthetic valve with a relapsing infection, these patients are also best addressed with a repeat operation. When it comes to dental prophylaxis, this is something that has changed over time. But in essence, if these patients have an extensive dental procedures that involves manipulation of gingival tissues, manipulation of periapical regions of the teeth, or have a perforation of the oral mucosa, then these patients should be prophylaxed with antibiotics. If they have any prosthetic valves, if they have any prosthetic material inside the heart, such as a ring or cord, if they have a history of endocarditis in the past, if they have a history of unrepaired congenital heart disease, and also if they have a history of cardiac transplantation, since they are immune suppressed. So this is a long lecture. There's certainly a lot to talk about when it comes to coronary bypass and valves. And although I went into quite a bit of detail, this is not necessarily a comprehensive evaluation or discussion of everything that you need to know about coronary disease and valve disease, but should hit on most of the important topics of when it comes to the surgical management of coronary and valvular disease. Thank you.
Okay, great.
Perfect.